Quick, Power Rangers, we have to go fight the immunomodulators. Have you seen some of these before? Yeah, commercial. Humira is one of the biggest ones. Indro, it still comes on every now and again, but they're all in the same category. These help the symptoms of rheumatoid arthritis. It does not necessarily cure the disease. Well, nothing cures the disease. It tends to slow it down somewhat, but it lessens the symptoms more than anything, so the person can have a normal life. You have to remember that rheumatoid arthritis can start in someone as early as the age of 5. When you have juvenile rheumatoid arthritis, it can start at the age of 5. And then we think of arthritis, old people, but not always. I have a good friend who's in his middle 40s who's been dealing with rheumatoid arthritis for the last 10 years. Oh yeah, he's doing it. He's doing it. He refuses to get sick. So we have a tumor necrosis factor blockers. So these are this is the. I don't know why I keep pointing. I got my hand. Hold on. Okay. Technology is getting ready to bounce on the scene. Hold on. Hold your breath. Hang on to your seat. Here it comes.
We play along, okay?
That's right. If I do that really fast, I'll summon the Power Rangers. But this is the factor which causes the solidification of the fluid in the joints and causes the ends of the joints to start to deteriorate and then fuse together. That well, you have teeth, fingers have the big bumps in them, and they're all crooked and so forth because the joints have fused. Okay, and these things help neutralize that so that you don't have that. You still have use of your hands and your feet and wherever else it is affecting. It disrupts the inflammatory process. Here, with inflammation, is that we have the body as its own worst enemy. It's sending all these prostaglandins and everything else down there to fight the inflammation caused by rheumatoid arthritis. And the more stuff it sends down there, the worse the symptoms get. And the worse they have issues inside the joints because of all this white blood cells and everything else coming in there to fight the inflammation is now clogging everything up along with this factor. And that's all I'm going to say about that. We have some other ones. Again, the Remicade is like the Humira, the same kind of action. But we have side effects. These are all the side effects of those medications. And with those medications, a lot of these side effects you will see. Because we are dealing with an immune system, not just the degeneration of the joint, you're dealing with the body in general. Therefore, the body responds appropriately in these issues. And what happens is the physician may continue the medication because it is effective, and therefore will give other medications for the side effects which they are experiencing in order to prevent any more severe limitations and so forth from the disease. Why would elevated temperatures, infections, and sore throat be a major concern?
Immunomodulators.
We're dealing with, remember, immunomodulators. Okay, so we are affecting the immune system. This is an autoimmune disease. The body's fighting itself. So we lower the immune system basically so it stops doing that. And as you lower it now, it can have a chance of you get an infection, it can get worse, you get a cold sore throat, it turns into pneumonia and so forth because your immune system is not strong enough to deal with anything anymore. Does that make sense? And then Remicade, contraindications, renal hepatic disease. Again, when you look at these contraindications, you look at the side effects and so forth, not only is it telling you what systems are being affected, it's telling you what is or how the body is dealing with it. Oh, we have renal hepatic disease. It says you can't use it in that. So what does that tell you? It's excreted. It's excreted through the kidneys, which can cause more damage, and now we're going to cause more damage to the kidneys. It's metabolized in the liver, and therefore, if the liver is compromised, it's going to compromise it even more. So these are important things to remember, not just the medication itself, but when you see these things, it's an indicator of what's happening inside the body with these medicines. So you can look at it and say, okay, this is what happens with this, therefore this is going to happen. The person has renal disease, but they got to be on the medication because of severe rheumatoid arthritis. We know that we have to watch kidney function, see how they're doing. We got to follow hepatic or liver functions. And we know that the person is going to have further complications. We have to be aware of that. As nurses, we have to be one step ahead of that. So if they start showing signs, we take action, which may be nothing more than calling the physician and saying, get this guy off this medicine. It's no good. Anti-gout drugs. What's gout?
It builds up your uric acid.
The little person in green has no gouts and good gouts, right? It's the accumulation of uric acid within the joint. Generally, the big toe.
They do.
Interesting, huh? Although it can happen in fingers, but it generally happens in one joint, one or two joints at a time. It's not symmetrical. It happens on one side, not both. It can happen in a thumb, but it won't happen in the other thumb. Back a long time ago, even before I was born, a person who had gout, they were considered like royalty. Because gout is caused by uric acid. Where does uric acid come from? The meat, protein, which means that they could eat. All the peasants were eating hay and eating dirt, and these guys were eating meat. They're well off, that they have gout. There's something else.
And too much.
It may be caused by a number of different things. It really can. Most cases, the gout itself is caused by the accumulation of uric acid because of poor kidney function. It's not an uncommon symptom of someone who is has kidney failure, going through dialysis. It's not uncommon for them to have gout because uric acid is not being drawn off as readily as it would normally. Readily as normally. Can you say that in one sentence?
Readily as normal.
Okay.
Readily as is normal.
Yeah, thank you very much. Purine containing foods like salmon, livers, sardines you don't want to eat. So if you're a big fan of liver, salmon, and sardines, well, you got to change your diet if you got gout. Anti-gout drugs, as they have down here, they help with the evacuation of the uric acid. They are helping with the evacuation by neutralizing the acid. They're not going inside and pumping it out, but they're neutralizing it so now the body can get rid of it more readily. Medications that are used, we have inhibits the migration of leukocytes to the inflamed site, so therefore you don't have more inflammation in the area. So remember that Cox tube? Limits pain and inflammation. Well, this is one of those things that goes down and actually tries to relieve the inflamed site, but because you have an accumulation of uric acid and other stuff, this is adding to the problem. So they want to keep all the extra stuff out. It's like we have a car accident on 281 and everybody stops to look. Well, the leukocytes or the rubberneckers. Okay, so you want to keep them out of the way. Side effects, as you can see. Uric acid inhibitors, allopurinol is the drug of choice for gout. It is the most effective. Decrease the production of uric acid, and it's prophylactic to prevent gout attacks. Somebody has gout, what's another treatment that they can do? Gluten takes one, what's another one? Diet, oh, absolutely. Thank you, I'm looking for a plethora of diet therapy. But you change your diet, so you know you're not producing so much uric acid from your diet. So you may not be able to go down to the Longhorn Steakhouse every night and have steak. You may just have to wait for Saturday night. Adverse reactions that you see, it does cause visual changes or advise clients against alcohol, caffeine, and so forth, because they will increase uric acid. And contraindicated with warfarin, which means that, okay, it's going to interfere with that medication. Therefore, the physician would have to regulate accordingly. The other medication, the probenamide, or Benamid for short, another drug of choice. Increased uric acid excretion, and it blocks urea absorption, so it can get rid of by the kidneys.
So one increases the production of uric acid and the other one decreases
Excretion of, right. And it's not uncommon for a physician when they're doing medication to even have a combination, maybe a lower dose combination in order to do both. You can't get rid of it all together. Your body uses that for the formation of amino acids and the proteins, muscle builders and so forth. You need this kind of stuff. Most uric acid, though, is a byproduct of this fact versus a building block thereof. I mean, one of two things. Something magical is coming up, or I'm done with my lecture.
Yeah.
What are we talking about next?
Non-opioid.
Opioids. Okay. Your NSAIDs are generally used, whether used for inflammation, used for pain, and used for moderate to mild pain. Opioids are used for moderate to severe pain. Ouch, I stubbed my toe. Where's the morphine? That doesn't happen. Okay? Nor should it happen. So mild to moderate non-opioid medications, you can use aspirin, Tylenol, and those kind of things in order to limit or decrease pain. It's supposed on their fifth vital sign, pain. It really is. It used to be you did your temperature, pulse, respiration, blood pressure was a vital sign, but pain is an automatic thing when you're doing vital signs as a patient. Always they ask, what is your pain level? The important thing to remember is that even as students, is if you're in the patient's room and you're doing your vital signs and you ask how much pain you're in, and they say, oh, I'm an 8 out of 10. Okay, thank you very much, and then you go about your way. I've had students do that, and so give me your information. About an hour later, give me your information. Well, what? You're having pain, you got to tell somebody. Action has to be taken, whether it's mild, moderate, or severe. Action has to be taken, and the severity of the pain will determine what kind of medications are given. We've talked about NSAIDs already. and about Motrin and all that stuff. So we have one down there, Tylenol, which is everyone's friend. That became the wonder drug after aspirin. And then we have Toradol, which has similar opioid responses to the pain itself, but it's not as strong or severe. You don't have the severe side effects. You don't have all the dizziness and drowsiness like you would with an opioid, although some people will experience some. It's a very good one when you're having some, if you will, severe moderate pain.
It's a painful shot, though.
It's a painful shot, yes it is. You better want it.
But it does it.
It works. Yes, it works. Okay, NSAIDs, we talked about this already, right?
Yeah.
Okay, next. Tylenol. We're inhibiting the prostaglandins again. What does that cause? In Tylenol, though, rather than inflammation and pain, it tends to decrease pain, not the inflammation. That's why you had things like ibuprofen and all that stuff came onto the scene, because you needed something that would decrease inflammation as well as the pain. So maximum dose, 4 grams a day. How many milligrams is that? I'm proud of you. Okay. You don't want to go over that because it can become toxic, it can cause kidney damage, and it can cause irreversible liver damage. And we have other issues like thrombocytopenia. We talked about that before. You're taking Tylenol, going in, oral contraceptives decrease the effectiveness of Tylenol. So either you can't increase your oral contraceptive, but you can increase your Tylenol if that is the case. My mom would tell my sister, I had 6 sisters. My mom would tell my sisters, the best birth control is Tylenol. One between your knees, not a problem. Again, we have COX-2, COX-1 is not inhibited, so you don't have the gastric distress, decreased inflammation and pain. Again, primarily Tylenol decreases pain more than it decreases inflammation, although it does have some effect to it. We have other NSAIDs like your Celebrex up there and so forth, which are very good for pain. Caution, we've seen this before with our other NSAID slides. You got to be well versed on this by now. Good. Opioid analgesics, everyone's best friend. Morphine, codeine, Demerol, Dilaudid. These are for moderate to severe pain. Yes. Anything else is from moderate to mild. Okay, this is, we talk about moderate to mild pain. This is kind of like severe moderate to severe pain. Okay, the NSAIDs aren't working. Their higher level of pain control must be effective. Basically, the way these things work is in your body and your nervous system, you have a pain pathway, if you will, where you stub your toe, and then that pain goes up into your spinal column, and either you have a knee-jerk reaction and it goes back down to your toe and you're there, or it goes all the way up to the brain and it's like, this is severe, this is terrible. What the opioids do is it shuts that pathway down to where only a few of the signals are getting through, the majority of them are not. And it's important to note, even with opioids, is that the person who's having severe pain, they will continue to have pain on the medication. It doesn't take it away, but it limits it to where the body now is trying to readjust, come into equilibrium, and it works better. Okay? Side effects, goofy, drooling, all those things associated with opioids. Herbal contraindication, St. John's wort. There's two medications, or two things you never take with the other medication. One's called the MAO inhibitor, which we'll talk about later on. That's an antipsychotic medication. You can't eat, drink, or do anything with that medicine. And then St. John's wort, a natural thing, it contradicts everything you put in your body. So if you ever using this stuff, it does have some benefit to it, it does, but you combine it with other medications, it becomes dangerous. And that's why now the doctor or the nurse will say, you're taking any herbal medication, if you've taken it just once, you tell them you're taking it and when. Okay, so they understand if it's in your system or not. Side effects, as you can see here, one of the one that we watch most closely is respiratory depression. We're working with the nervous system. It's not going down to where the pain is and decreasing the inflammation. It's going into the nervous system to shut down that pathway so that the pain does not go up to the brain. Okay? Or at least all of it. That's what's happening. So when it's shutting down the nervous system, it's doing two things also. It's slowing the heart rate down, and it's slowing your breath down, so that your respiratory rate is going down as well. Morphine, more than the other one, is more effective in bringing the respiratory rate down. We have to be very careful that dosages aren't high enough to be able to cause that problem. Tolerance, dependent, withdrawal are a big issue with medication, but we're talking long term. You're not given 30 days with this medication and then you're afraid to take it because you think you become addicted after 30 days. That will not happen. It has to be over a period of time that occurs. You can gain a dependent or tolerance toward the end of that time, and all that, and the way that is treated is just take away the medicine, tell you to go to Dairy Queen, cheer up for a little bit, and then the need for it will go away. And contraindication with head injury, increased cranial pressure. With head injury, why wouldn't you want to take it with head injuries?
You're sleepy.
Very good. It depresses the CNS, so therefore you don't know if they're groggy because of the injury or because of the medication. A lot of people with head injuries, they give Tylenol to initially, and you go, why? They're really, well, because anything else will interfere. With intracranial pressure, does anyone know why that's not given for that? Vasodilate, so it actually increases intracranial pressure. When we talk about bringing the blood pressure down, bringing the pulse down, is that the blood vessels dilate, causing more blood to flow through. Then what happens is that if they have a head injury, then more blood gets up into there, now we have a major problem. So, contraindication for opioids. We have mixed opioids, agonist and antagonist. Nubain is the most common. It bonds with the opioid receptor and increases the pain threshold so that the person is not in pain as much, or they can tolerate more on this medication. And you see it says better tolerated by women. You can make up your own little rule of why that is. I can tell you, but your head will swell. What'd you say? Anyway, disadvantages. decrease the risk of opiate abuse, safe during labor, IV use, pain control in 2 to 3 minutes. So we don't have some of those things as far as abuse and dependency and so forth as we do with the opioids, your opiates. We come from the poppy, we go from there, we go into morphine, we go into Demerol, and so forth and so on until we get down to a weaker state. Side effects, with medication and contraindications, as you can see up there. Again, you see renal and hepatic dysfunction, which means you know where this stuff is excreted and how it's metabolized. Then we have opioid antagonists. What's an antagonist?
Works against.
It blocks or shuts down, exactly. Naloxone, I always mispronounce it. Narcan is the drug of choice. You have someone who's having severe side effects from your opioid, their respirations are depressed, they're really sedate. You can't arouse them, you give them Narcan, and with a matter of seconds, they're back with you again. It works very well. Side effects, as you can see, but again, it's used for overdose of opioids or severe side effects from opioids. Therefore, the side effects you'll deal with. You have 2 choices: deal with side effects or bury the person you couldn't bring around. I'd rather deal with side effects. Yes, ma'am.
And that's normally given through an IV?
Correct. Yeah, because most times they're sedated or semi-conscious or unconscious and so forth. So that. But again, onset's very good.
I finally get to play with you and
Methadone treatment. You probably heard about this before. Anything with drugs and with drug withdrawal program, they have a methadone program so that they will still have whatever relief they have, but it is now in a non-drug or habit-forming medication. They don't like it. It works, but it's not as fun as opioids. But it works very good for pain. And someone who uses drug dependent, it works very good for pain, but it's not the same environment that they wish they had. Sometimes. Correct. Medication, the Orlam specifically is not used in United Kingdom or Canada because of severe side effects. Because of life-threatening adverse reactions. They have used this medication. People have died, therefore they pulled it off their shelves and said we will not use it anymore. The U.S. is one of the few countries that still use it.
So that's like one for other people. Why we still use it? We don't care about our. Yeah, that wasn't on our
Is that
slide.
Orlam in our book?
Like this
Even?
slideshow is very different from the one that we have.
Oh, should be the exact same one.
We just don't have
The
that
last
stuff
one.
on there.
I just pulled some slides off of it.
Is the Orlam in our book? I didn't see it in our book.
Oh, no, Orlam was added, you're right.
Okay.
The next slide. Yeah.
Very good.
So for
That one I
test
added.
purposes, can you re-add the slides so we know all that?